Thank you, Samir. So just from a technical note for the IT people, we've lost the monitors here in the front. If you could help fix that so we can stay up here for the live cases. We have about maybe 2 minutes for discussion left before the live cases. So maybe we could just ask sort of one question of the panel. I had written a bunch down, but maybe the one that's sort of most relevant is, what do we do nowadays with the 65 to 70-year-old low-risk patient, maybe with the bicuspid valve or without? How do we advise that patient about surgery, thinking TAVR down the line, versus TAVR, thinking TAVR down the line with what we know about today for TAVR and TAVR? So Kendra, why don't you start with that? That was sort of your topic.
Well, I get to cheat because I just presented that case. A 65-year-old with
But how do you
bicuspid
talk,
severe aortic
more about how you
stenosis.
talk to the patient about those risks?
And that's exactly the shared decision-making piece. I still advocate, like what Vinny said, I would have put a mechanical valve in him if he would let me, but no patient wants Coumadin now, especially if they're 65. I can probably talk patients younger that into it, but if you're 65 and you have the choice of TAVR, you're probably not going to say yes. So we have to talk about all the options and a balanced approach. What are the risks? What are the benefits of all of the therapies? And what are the expectations? And so I'll have that same conversation with the patient. I don't know the durability of your TAVR valve. I will use the data that I presented and say, I would guess out to 10 years it's probably the same, but if you choose a biologic valve, somewhere down the road you're going to need something more. And whether that's a TAV and SAV or a TAV and TAV, I don't know how long the TAV and TAV is going to get you because we haven't done enough. When we started with high-risk or inoperable patients, they didn't live long enough yet for us to answer these questions. And so I have the conversation and then try to help guide them into what I think is a reasonable approach for the patient I presented. He understood that valve is not going to last his lifetime. I would expect it to get him to 75. And if it does, we can probably put another valve inside, but it doesn't get him to 90, and he knows that.
Samir, do you have a different conversation with your patients?
I do, because I think that the simple conversation is to say that how long you're going to live. So if they are going to live at 65 for 30
low
years.
risk. We're talking about
Low risk. So yeah, 30 years. If they're going to live 30 years, I think that TAVR, SAVR, TAVR is a better option than doing SAVR first, because if you are going to do SAVR first, then you're stuck with another operation at some point, because TAVR, SAVR is not a super option. So the last option has to be TAVR. So now we are deciding SAVR or TAVR first. So this is what I ask them and suggest to them that, listen, if you think that you can have a safe operation at 75, and if the valve that we put is such that you can take it out and put a new valve relatively easily, then this is a better option. And especially if their aorta is not super dilated, or it may dilate in the future, or if they may develop coronary artery disease, that will be treated at 75. So these are the conversations I have. So it's slightly different.
Of course, most patients who are 65 are not going to live 30 years. And
hope
most
they
are
do.
going to get two valves, not three. The average life expectancy in the U.S., which is dropping, is around 84 years old. And if you have AS to begin with, it's probably a little less than that. So I think we're mostly thinking about two valves for these patients, not three.
So the life expectancies of general population, we are talking about low-risk population coming to you at 65 who are very well characterized. So their life expectancy may not be 84, but maybe 95. Because, no, these are different population. Because if you look at the aortic stenosis population, their outcomes are better than general population because they are well characterized. So this is where I think you have to have a different conversation.
All right. I think maybe we have time for one quick more comment, George, or do we need to move on?
Can I just make a comment? I think we can debate this forever, and cardiologists are always going to say do TAVR. Surgeons are going to do SAVR. But I think the main question is, like in surgical devices, last 10 years, we have made effort to modify surgical devices to allow valve-in-valve. Expansion mechanisms, leaflet heights, TAVR designs need to change. I strongly believe, I like both technologies. I strongly believe that the current TAVR designs, and especially with the ask we all have, implant higher, is not good for the second procedure. And I think we need to modify the way we treat people if we want to keep the second good TAVR option open for most of the patients.
All right, great. I think we wrapped up a great first session, very dynamic with all the expert guest speakers here from around the world. Welcome also from myself, George Dangas, a course co-director today, and we're going to see two very challenging life cases. May I have Dr. Hassan Jilahavi please join the panel as well? Are you there already? You joined already the panel. Excellent, even better. Joined from